Dr. Shi is internationally recognized as an expert in nuclear medicine. He is especially renowned for his pioneering work in applying photobody PET-CT knowledge technology in clinical research and practice. His team has conducted photobody PET-CT imaging in over 35,000 patients in the past 5 years. He has published over 200 peer-reviewed articles as the first author or the corresponding author. And over 40 of the articles are about the imaging on photobody PET-CT scanner. And he's also the author of several textbooks. He served as the Vice President of Chinese Society of Nuclear Medicine and Molecular Imaging from 2017 to 2023. And he currently is the President-elect for the term from 2023 to 2026. He also served as the editorial board member of European Journal of Nuclear Medicine and Molecular Imaging. Dr. Shi has received a number of awards, including the prestigious honorary fellowship from the American College of Nuclear Medicine since in 2017, and the American Society of Nuclear Medicine and Molecular Imaging Presidential Distinguished Service Award in 2020. Dr. Shi's lecture today is about the clinical application of photobody CT. Please join me in extending a warm welcome to Dr. Shi as he shares their expertise and engage in exchange of the knowledge. Thanks.
Thank you for the introduction. Good afternoon, everyone. I'm greatly honored to be invited to attend this grand round and to address on the topic of photobody PET-CT application. I'm from Zhongshan Hospital, Shanghai, China. So our hospital is the first large hospital established and run by Chinese people. And also, our hospital is a major teaching hospital affiliated to Fudan University. And our hospital ranked third in China. And we served 5.5 million patients a year. So many patients every year. All the disciplines in our hospital is strong enough. So all those disciplines that's very famous in China. And our department of nuclear medicine, was established in 1958. It's one of the cradle of clinical nuclear medicine in China. It's the national key clinician specialty and the national demonstrated base of standardized training for residents and the national base of clinical drug trials. You know that in China, the nuclear medicine is dependent, not belong to the radiology. That's the same level. So something that's different from American. And our department has an area of approximately 5,600 square meters and consists of 4 centers. And this is the PET molecular imaging centers. We have 4 PET-CT scanner and 1 PET-MR system. In the last year, 27,000 patients underwent PET-CT examinations. And this is the single Fulton functional imaging center. We have 3 SPECT and 1 SPECT and 2 dedicated gamma camera. And in the last year, 22,000 patients underwent SPECT examinations. And this is the radionuclide targeted therapy centers. And because that not just only for the radioiodine therapy, we also use that lutetium in clinical practice right now. And this is the Molecular Probe Research Center. We have the 20 MeV cyclotron with solid target and have 10 hot cells. And we use that the gallium as the routine works. Our department and our hospital is open for the world. So every year there are so many international experts visit our department. And some of them have built international communication and cooperations. So that's the experts from all over the world. And the first total body PET-CT scanner in the world was installed in our hospital, in our department, in April 2019. After 5 years clinical practice, 35,000 patients were examined right now, including more than 4,000 dynamic studies and 5,500 low-dose studies and more than 1,000 low-dose filtration studies. During the past 5 years, we have published about 50 papers in English and Chinese. So what's the new for the body PET-CT? Thanks to that the 194 centimeter AFOV, it not only could cover the whole body, just the one bad scan, but also provide that 44 effective count rate more than conventional PET-CT. So the reconstruction spatial resolution is approximately 2.9 millimeters. So those characters just from that the series. How about it in clinical practice? So firstly, we validate its performance in clinical practice because it have a large coverage. So just the one bad scan, we can get that the whole body imaging. That's something different from that the conventional PET-CT. From this imaging, we can see that all those lesions in arms and in the actual lower limbs, all those lesions was covered. So sometimes we always think that even we use the conventional PET-CT scanners, we can scan 2 times, we can cover all those range. That's true, but it always takes a long time. But if you not pay special attention in advance, probably you will lose some of these. Especially for these arms, usually we just that the patient, the arm or head. Sometimes this lesion will be lost. But for our routine works, just like this, all those lesions should be covered, just the one bag scan. So everything is so easy. And because it have that the 1 meter and 94 centimeter AFOV, so the sensitivity improved a lot of. How about the sensitivity for the lesion detections? So we enrolled a group of the malignant tumors patient. We performed that head-to-head the study, and the patient after inject the regular dose FDG, we performed the conventional PET-CT scan. And then immediately, we let the patient perform the total body PET-CT scan. Just the 5 minutes acquisition time. And then we rebuilt those imaging into that the 1 minute, 2 minutes, 3 minutes, and 4 minutes, 5 minutes. And then we analyzed that those lesions detections. Finally, we found that when we use the regular dose, the regular dose PET-CT, we can see some smaller lesions, and probably that's the lesion to the background, the lower the lesions. So just we conclusion that we can detect the small size the lesions, probably that's the 4.3 millimeters, and the FUV, SUV max, that's only 1.0. And some of the low uptake lesions, that the lesion to the liver reach just only 1.6. So for this lesion in the livers, so probably for this, just compared with the conventional imaging, we cannot see it. But using the total body PET-CT 4 minutes, we can catch it very clearly. So finally, we found that if we use the total body PET-CT with the regular dose FDG, the acquisition time not less than 4 minutes, we can get the good imaging qualities, can catch the small lesions. And because that's the whole body imaging, so we think that just using that the total body PET dynamic scan, we can see all the total body, all the organs in the total body, the biodistribution of the radio tracer. Although we use the conventional PET-CT, we put the cover that from head that to the middle side here, but we never know how about the FDG distribution in the body at the same time. So we performed that the dynamic scan. That's the acquisition time is the 55 minutes. So this is the first time we got the full information about the FDG distribution in the total body. And this is the health volunteers. And then we draw the ROI in the different organs. We got the TAC curve of the different organs. So we can just according to that the TAC curve, we know that the FDG distribution with the time. So we never just we usually just analyze that the static PET imaging. We never know that the time windows of the biodistribution of FDG in the total body. So that's the first time we know those informations. So after we got these informations, we further exploration and validation of the potential clinical application of the total body PET. We focus on that the low dose and the fast scan. So for the low dose scan, we always think that if that the dose is lower, so probably we always think that the biodistribution will be changed, will not be as the same with that the full dose. So we enrolled a group of the health volunteers, and we randomly allocated those health volunteers in 2 different groups. One group was injected the full dose, and another group was injected the 1/10 dose. And after we injected the FDG, we performed the 75 minutes dynamic scan. And from this imaging, we can see that all that FDG biodistribution almost the same in the full dose group and the 1/10 group. And this is just the visual analysis. So we performed that the semi quantitative analysis. So we draw that the ROI in the different organs in the full activity group and the ultra low dose group, and compared with that the TAC curve, we can find that except the peak value of the FDG in the full activity is higher, and in the ultra low dose, that means 1/10 dose is lower, but the shape of the same organs almost the same. So that means that even we use the 1/10 dose, the FDG, the biodistribution in the human body, that's the same with the full dose. So that means that for the health volunteers, they have the same biodistributions. That's just for the health volunteers. How about in the patients? So we enrolled a group of the malignant tumor patients, and the first day we gave that the patient gave the patient injected the one-time dose, and the second day the patient was injected the half dose, and after we injected the FDG, we performed the 75 minutes dynamic scan. So just from that the planar imaging, we can see that the biodistribution almost the same. And also we can see those lesions in the liver and in the colon. And in the one-time dose group and in the half dose group, we can see it very clearly. And then we draw the ROI and to get the TAC curve in the different groups. And from compared with each group, we just found that the peak value that's the lower in the one-time group than in the half dose. Just to see those lesions, this is the one-time dose here. We can see it very clearly. And the half dose also we can see it. So that means that even for that the malignant tumor patient, we use the one-time dose, we can see all those lesions. We will not miss any small lesions. So after we got this, we validate these findings, we use it as our routine works. So we always think that if we use the low dose, probably that the target to background ratio should be lower. So we analyze that the one-time dose group and compared with that the half dose group, we found that the target to background ratio almost the same in the same time point. So that means that if we use that the one-time dose, if we have the enough acquisition time, we will not decrease that imaging quality, and we will not lose the small lesions. So finally, we validate that. How about when we use the one-time dose, the acquisition time for the total body PET-CT scan? So we enrolled a group of the patient using that the regular dose. We just the acquisition time, that's the 2 minutes. And also we use that the one-time dose, and the acquisition time is 10 minutes. And then we rebuild the imaging, that's the 8 minutes, and compared with each other, we found that the 8 minutes imaging in the one-time dose, the imaging quality, that's the same with the 4 dose 2 minutes. So that's our routine works in clinical right now. If we use the one-time dose, probably we just the acquisition time, that's 8 minutes. So we built the SOP. So our routine works use that protocol every day. We all know that for the dynamic scan could provide more information, but it always takes a long time. For example, usually the acquisition time, that's the 75 minutes. So that the patient lay on the bed for so long time is uncomfortable. And it always takes a long time for the scanners. So many patients will waiting there. So convey that using that the short time can get the same results. So firstly, we got the result is that when we use the 45 minutes and the compared with that the 75 minutes dynamic imaging, that's the kinetic matrix of FDG almost the same. So that's the first step we got the study. But and then we performed the further study. We got the results that when we use the dynamic scan, even that for 30 minutes dynamic scan, we can get almost the same results. So why we performed this kind of the study? We all know that for the clinical trial, for some of the new radio tracers injected in the body, and we just using the regular method to evaluate the blood concentrations. So it always takes a long time, but we just get the blood concentrations. We don't know that the radio tracer biodistribution in the human body. So in our center right now, all the radio tracers clinical trial will perform that to the body PET scan. So just according to the total body scan, if we found that the radio tracers accumulated in the target lesions, that means that should be effective. If that the radio tracer distributed in the other organs, probably that's the side effect. So just that the one dynamic scan, we can get more information about that. And sometimes we just using that the 30 minutes dynamic scan, we can get enough information. So that's why we focus on to study that the short time dynamic scan meaning. And sometimes the patient will lay on the bed for a long time. It is challenging. So we perform that study to investigate the how fast of the total body PET scans should be. So we enrolled a group of the patient. We performed that 5 minutes scan, and then we rebuilt the imaging into the 30 seconds, and compared with the 5 minutes group. And finally, we got the result is that the 5 minutes group had higher accuracy and larger areas under the curve than the 30 seconds. So although that the 30 seconds is not as good as the 5 minutes, but sometimes it's just for short time. For some situations, it could meet some special request. So we performed it sometimes in clinical practice. For example, this is the patient with the lesion, metastatic lesions in the liver. That the 5 minutes we can see it, but the 30 seconds lose it. So from this imaging, we always think that if we use the conventional PET-CT scan, how many small lesions was lost? If we don't compare it with that total body PET-CT, we never know that. So right now in our centers, when the patient will visit our department, we will evaluate. If we think that probably the patient will have the small lesions, we will let the patient using the total body PET. Otherwise, we will let the patient using the conventional PET. So that's the different situations in our centers right now. And we have built those standard operation procedures. So how about its clinical application right now? For some patients suffered from the system disease, will have a lot of the lesions in the whole bodies. So the total body PET-CT have the advantages over the conventional PET-CT scanners. So when the patient visit our department, that the nuclear medicine physician will evaluate the situations, and we will let the suitable patient to using the total body PET-CT scan. And after the total body PET-CT scan, we can catch all those lesions in the whole body. And it is more sensitive than other imaging modalities. For example, for this patient, although the MRI was performed and really found abnormals, but anyway, that's the regional. We cannot get the whole body information, but just the whole body PET scan. From this, the MIP imaging, we can get all those informations. So that the total body PET-CT, that the complicated the situation became that very easy. So for sometimes that the Takayasu arthritis always evaluation using the MRI in clinical practice. But sometimes the MRI is not so sensitive, and sometimes we'll lose that the small lesions. So in China, most of the centers using the FDG PET to evaluate that the Takayasu arthritis. For example, this is the case in our centers. For this kind of the patient, we just performed that the total body scan after the radio tracer injected 2 hours later. Why we use that 2 hours later? Because that those activity inflammation lesions in the aortic walls, if that the blood pore activity is higher, now obviously that the lesions could be seen. So 5 hours later, we can see that the small lesions were clearly because that the blood pore activity decreased obviously. So in our centers, usually we perform that the 2 hour later imaging. If we get enough information, that's fine. If we cannot get the enough information, we will continue to finish that 5 hour delay imaging. So if we can find that this activity inflammation lesions, that the patient will accept that the high that the doses the high hormone that the therapy. So this is another case. This is also that the young girl suffered from that the Takayasu arteries. Just from that the 2 hour imaging, we can see it very clearly. And from that the 5 hour later imaging, we can see some that the another location that the imaging that the lesions there. So that means that sometimes that the very small lesions was not could be found in the 2 hours, but in the 5 hours we can find more. But sometimes that if we kind of one lesions, that's the same with that could be found 10 lesions. Just the one is enough. So if we can find that in the 2 hour imaging, that's enough. Sometimes that the dynamic scan could provide additional information. For example, this patient was suspected of suffered from that the neuroendocrine neuroplasms. We can see that lesions in the front of the pancreatic tube. We can see that the enhanced MRI that the lesions here. So because that the patient is suspected of the neuroendocrine tumors, the visit the Department of Nuclear Medicine to perform that FDG and the dotted imaging. And all those imaging was performed that dynamic scan. Just the analyze the imaging using that the visual analysis is really difficult to compare those lesions uptake that with that the spleen. So we use the analyze the dynamic imaging. We can see that the TAC curve of the spleen that goes up that with time, and also for this the small mass here is also goes up with the time. Although that the peak value is different, but this curves that's almost the parallel. So just according to that the visual analysis and combined with that the TAC curve, we give that the diagnosis that's the accessory spleen of this mass. And finally, the pathological diagnosis of the surgical was confirmed our diagnosis. And another case that almost the same. Also, we can see that the small lesions in these areas. And from this, just the visual analysis, we just see that very little uptake of the dotatate. So according to the CEC curve, we can find that the spleen uptake of the dotatate goes up with time. But for these lesions here, that's very lower. So we don't think that is that the accessory accessory spleen. And finally, the pathology diagnosis confirmed that that's the insulinomas. So sometimes that the dynamic scan would really provide additional information, although it always takes a long time, but sometimes it's worth to do that. So for some challenge case, we will do that. This is another challenge patient case. So this patient suffered from the prostate cancer and accepted that the endocrine therapy right now. And also this patient underwent a lung carcinoma resection half years ago. And recently MRI imaging demonstrated that so many the multivertebrate with abnormal signals. And the biopsy pathology diagnosed that is the neuroendocrine tumor G2. So as this patient suspect of the neuroendocrine tumors, the patient visit our department. And firstly, we let the patient perform the FDG, and the second day, we injected the dotatate. You can see that the FDG and the dotatate that's used at the lower activities. So just compared with the FDG and the dotatate imaging, we cannot get the solid evidence to support that the patient suffered from the neuroendocrine tumors, because that this patient suffered from the prostate cancer. So we advise this patient perform that the PISMA imaging. And after that, we really confirmed that those so many that the lymph node metastasis lesions just around the aortas. And also there are so many that the lesions in the column uptake of the PISMAs. So when we finish all those the low dose, the 3 kinds of the radio tracer PET imaging, and we again perform that multidisciplinary team discussions, and finally that the pathologist reanalyzed the slides and modified the diagnosis as prostate adenocarcinoma metastasis with neuroendocrine differentiations. So just think about, if we don't use that the low dose, the patient will not accept that 3 kinds of the radio tracers in short time. So the low dose radio tracer really give us so many help. And this is another case. That's also the neuroendocrine patient. And usually we use that the 2 kinds of the radio tracers. The first day we using that the 1/10 dose of the FDG, and the second day we give that the 1/3 of the dotatate. And from this imaging, just according to that the PET imaging, the PET CT imaging, we can see those lesions very clearly. But we let the patient perform the PET MRI, we can see that those lesions demonstrated in the PET MRI is more obviously than with that the total body PET CT. And that's very interesting is that just from that the T2 imaging, we got the relationship between the tumor with the bile duct relationships. We can see that the lesions here, that's the obstruct of the bile duct here. So we can see those lesions very clearly. if you just think about we just using the FIR imaging, we just see that the mass here. But for the PET MRI, we can see those lesions and we can evaluate the activity of these tumors. So more information we can get. So sometimes we think that even we use that the low dose of the dotatate, but the PET MR is also sensitive enough. So that's another question is that we always use that the recommended dose of the radio tracer. So is it correctly? Who knows? That's the question. We always fit with this kind of questions. And this is another very interesting case. This is a patient suffered from the neuroendocrine tumors. And at the baseline, we performed the FDG and the dotatate. We see those lesions very clearly. So after the therapy, the patient visit our department, performed the follow-up imaging again. If we just the evaluation that the therapy response, we just according to the FDG imaging, we will find that those lesions no uptake FDG, probably that's CR. Just that the same location, then we can see that the dotatate imaging, we can see that those lesions became small, uptake decreased a little bit. So probably that's the partial response. It's not the real, that's the completely response. That's the same patient, that's the lymph nodes here. That's also in the baseline over, that's the demonstrated very clearly. But in the after the therapy, almost disappeared because that this lymph nodes is small, very, very small. Probably just according to the RECIST 1.1 standard, it's difficult to give the answer. But just according to the radio tracer uptake here, we can see that clearly. And that's the same thing, that's the dotatate imaging, we can see it very clearly. Probably finally, we give that the result is the partial response. So, and then we tell that the oncologist probably that the chemotherapy is good enough. And probably, and this time, you should focus on that the neuroendocrine tumor therapies, not focus on that the chemotherapies. And it's also, we use that the one-time dose. You can see that the patient accept that the immunotherapy combined with the chemotherapies. At the baseline, we perform this imaging, we can see that the lesions in the liver very clearly. So because we just use that one-time dose, so every month we let the patient perform the total body PET CT. We just perform the total body PET CT using that the attenuation correction CT, not the diagnostic CT. So we can get the imaging very clearly, the PET imaging very clearly. Just compare that the second with the first one, we can see that the lesions decreased, that size decreased very clearly. And for the third time, that further became small and uptake decreased. And the fourth time, we can see that the lesion became increased, the size increased. Just thinking about, without the middle two times, just compare the last one with the baseline, we will give the answer is that the patient have got the benefit. You can continue to use this protocol for the therapy. So that's the low dose, that's the one-time dose really help us resolve a lot of problems. This is that's the MIP imaging, and this is the tomograph imaging. We can see that all those lesions demonstrated here. So we use that one-time dose really help us use in the different situations. Just now I have introduced that we use a lot of the dual tracers, but sometimes the dual tracer, it always takes 2 days. One day use one radio tracer, and the second day we use another kind of the radio tracer. And also every time we're using that the PET imaging, we will perform that that the CT scan. At least that you should perform that the attenuation correction CT. And at least you have that diagnostic CT. So according to this situation, we built that the one-stop dual tracer PET-CT scan. That means that at the first time we injected the FDG, that 1 hour later, we perform that the total body PET scan. And after the PET-CT scan, we let the patient lay on the bed, not moved, and then inject another radio tracers. And then we continue to perform that the 1 hour dynamic scan. So using these protocols, we just finished the one CT scan. We'll finish all the full radio tracers PET-CT examinations. So we can get more benefit from these protocols. That's the lower registration burdens, because that one diagnosis CT need and with the lower radio tracers. The first radio tracer, that's the 1/10, and the third, that's the second, probably that's the 1/3. And also that's the single examinations in the single day. That the patient finishes the examination in 1 day. And another thing is that finally we got the imaging, that's the dual tracer imaging. Sometimes we just think that we use one kind of the radio tracer, probably have a little bit uptake. And another radio tracer will be used, probably that's also a little bit. That the reasons probably that's not obvious, but we put them together, we can see it more clearly. So that's another benefit. And just from according to this, we just built compared with that the imaging in the one that the 30 minutes compared with that that's the 1 hour, because we use that the FAPI imaging. Everyone knows that for the FAPI imaging, we have not that standard operation procedures. So just compared with the different time, the imaging quality, we found the 35 minutes after radio tracer injection, the imaging quality is good. So we just published the paper and we use it in clinical right now. And sometimes we think that why we always focus on the fast scan. And and this is another case that's like a high sensitivity. That the patient suffered from that the lymphoma. After we finished the regular examinations, probably 10 hours later, we found that we probably lost some lesions. So we call the patient back and then using the total body PET-CT scan to perform the regional imaging. And we can just according to the records, we can find that 10 hours later, we use the total body PET-CT, we also can get the high imaging qualities. So that's the high sensitivity bring us the benefits. And this is the patient, that's the big size, could not lay on the bed for a long time. So we inject the regular dose, and then that the 1 minute imaging, we can get the high quality imaging to meet the diagnostic request. So compared with just according to the body imaging, that the imaging quality is not so good. But compared with the conventional PET-CT, the imaging quality is good enough. So this is that's the special situations. And just see this imaging, we can see that during acquisition, the patient is motion. But just using the conventional PET-CT, we got this imaging, that the imaging is blurred. So we cannot get the high quality imaging, because that's the total body PET imaging. So we rebuild the imaging, and then we get a series of the different time point imaging. Finally, we select one of the high quality imaging, and then to meet our diagnosis request. So that's the fast scan bring us the benefits. So everyone knows that the total body PET-CT is more expensive, it's not so popular. Because that our center, that's the first user in the world. So after we have a long time the clinical practice, we built the standard operation procedures. And the last year, we have published the first experts consensus on the total body PET-CT. And we told that all the users, when we use the different radio tracers, different activity radio tracers, and we can select the different of the acquisition time. But above all is that there are so many optional protocols. How can we select that? So we built another protocol. That means that when the patient visits our department, we will collect the medical history in detail. Just according to the information, we will decide on site what kind of the dose should be selected, what kind of the dynamic scan or the static acquisition should be selected. So that the personalized imaging processing and acquisition timing were established. So, and that's published paper last year. And recently, we just submitted another the workflow of the total body PET-CT probably will be published at the end of this year. So in conclusion, that the total body PET is a powerful new device leading nuclear medicine to the era of the personalized technology. We can optimize the PET-CT acquisition protocols according to the patient's needs and minimize the patient's discomfort. And for patients with good general conditions or pediatric patients, long-time scan using half or one-time dose is preferred. And in well-selected cases, fast acquisition protocol using regular dose is feasible. And the dynamic scan is a potential method for clinical research and well-selected clinical cases. So that's what I introduced today. Thank you for your attention. Thank you.
Thank you, Dr. Shi. And this is a very new scanner for us. And I noticed that they're using refractory. It's a new radio tracer. Hopefully, it could replace the FPG that we're routinely use with better sensitivity and accuracy. Is there any question that you?
So for that, the dual tracer imaging, where you inject all tracers at once, do you try to put back one from the other, or do you just look for the signal of both the tracers together?
Yeah, good questions. For the two radio tracers, we just firstly inject the one radio tracer. And then after we finish the acquisition of the first radio tracer, and immediately inject the second radio tracer. Because right now, we cannot separate the different radio tracers in the same imaging. Yes.
That's a problem.
Yes.
But then can you subtract the combined
Yes.
signal minus the first injected? And then get a kind of a pseudo readout in the second tracer?
Yeah, that's good questions. Yes. Yeah, that is depending on the situation. If we use that for that's the diagnostics, we will select the target radio tracer as the first tracer. Because that the first tracer distribution will decide if we will use this the same tracer as the therapy. And then we will combine another one. That means that if we can find more lesions, if we can find, that means that the tumor that the heterogeneosis is obviously. Probably we can get additional information just depending on that the theranostic probably is not enough. We should combine another kind of the therapy method.
Noticed that was fascinating and really exciting. I noticed that some of these scans you did quite late, and the number of patients that you're scanning per year. How late in the day do you scan, and are you operating this 7 days a week?
Good questions. Yeah, in our centers, we never work 8 hours. We will start our work at 7 o'clock in the morning. And finally, we will finish all the works. We will back home at least 10 hours. So every day, we will have more than 100 patients. I'm here, so yesterday, we finished 120 patients, just one day.
The PET-CT.
Yeah, for PET-CT, not include PET-MR.
Do you have more photo bodies scanner or what the ratio, the percentage of the photo body and the conventional?
Yes, just depending on the situations. In our centers, we have a lot of the clinical research works. For example, for the clinical trial, to evaluate that some of the new tracers, we will have the priority using the total body type. If we have not this kind of study for this research works, we will use it for the routine works. If we use it very quickly, we will finish probably using the photos. That means that the 3.7 MBq per kilogram, just 3 minutes, we can finish it like one person. You know that the 3 minutes that the image quality is pretty good. But that's another challenge is that how many physicians you have. That's very quick. Yeah, please.
Okay, the total body PET-CT is nearly about 10 times price of conventional PET-CT. So for each patient, how can patient afford or pay that higher cost, right?
Yeah, that's the cost. That's the same.
Same cost. Okay.
Yes. Yeah. For the patient, you just pay the same. Yeah, because that's the workflow. That's the totally different. But at the same time, you can serve the more patients.
And you said that's because you can scan, the acquisitions are quicker, and so you have more patients going through?
Yeah, yes. Yeah, that depends on the situation. If you just want to have the more workflow, you can use the photos regularly. For some patients, that's care about the radiations. So we will let the patient perform that's the low activities. But sometimes, we work for a long time. When we will finish that at the end of the day, that the radio tracer is not enough. So at this time, we can use that low dose, that more patient finish the examination at the same day. Save a lot of money.
120 patients on a whole body PET, or is that all your PET scans?
Yeah. Yes. Yeah. We have that. Just the why we just do something. Just want to know how many patients could be done in 8 hours, and we really do that. 50 patients, 8 hours, using that total body type. Yeah, one by one. Yeah.
So how many PET images that the individual attending surgery per day? Yeah, because you have more than 100, and how many physicians you have to read the images? Yeah.
Yes, you know, in our department, we have that our staff is that 60. We have 30 nuclear medicine physicians. And now we have 12 residents with some training in our centers. And also have some of the doctors from all the country to our hospital with the training, almost more than 20. So they can help us do a lot of works. Otherwise, we cannot do that.
Your dynamic scanning, you said you're doing 75, you could do 75 minutes for the whole study.
Yeah.
Do you guys do anything, do you ever take a lot of data up front in the first 15, 20 minutes and then take patients off and bring them back at different time points instead of just scanning for the whole 75 minutes?
Yeah, that's the good questions. That's true. So right now, if we perform that the 75 minutes dynamic scan, we never use that the full dose. We use that the 1/3 or that the 1/10, because the data size will become small, very small. So it will not take a long time to storage for those data. Yeah, that's a good question. That's really a challenge for that the total body PET. Even for that static imaging, that the data size is really big.
Regarding this whole body PET scanner, if you did a scan and realized there was significant motion in a particular segment of the head, and you have to do a new acquisition, do you have to acquire the whole thing again, or can you have it just acquire that segment?
Yeah, you know that the total body PET. When the patient just lay on the bed, you will finish just one bed like the total body. Otherwise, that the patient is longer than 2 meters. So sometimes we just get the regional, because that we don't want to perform that the big range for the CT scan. So for the PET scan, just one bed you can get the total body. But if you get the good imaging quality, you need that the CT scan. If we just want to reduce the CT dose, so we just scan that the targeted reasons. Other reasons we will not scan it. So finally, we just get the regional CT image.
But if there was motion, you can retroactively go back and get, a minute of that acquisition data where they're still.
Yeah.
And look at it there.
Yes, you know that after we finished the acquisition, all those data was stored that in the disk. So we found something wrong, we will just rebuild the imaging. That's very quickly.
So is the software has the can take care of the motion artifact or?
No, just the visual analysis. Yes.
Okay, one more question about is it an alternate dose? I know that the total body is benefit is for whole body for adults. Have you tried any pediatric patient kids, because that's lower dose would be beneficial for the children?
Yes, we use that. You know that for our there is a children's hospital affiliated to the Fudan University. That's parallel with our hospital. So in our hospital, that's very limited that the children. But sometimes we really do that. Yes. 1 time dose is good enough. Thank you.
Thank you very much for the excellent lecture. And we have a question for you. This is from the department.
Excellent. Take a picture.
Another one from nuclear medicine.
Oh, yes, so many.
Again, it's a ball.
Okay, me next. Okay,
Thank you.
I don't know.